Based on the work that I'm doing, I chose to talk about caregiving challenges, stigma and social isolation, resilience, and planning for long-term care and end of life. The first three bullet points have been increasingly addressed in the HIV and aging literature, but I'm hoping to add some new insights based on our work. The fourth bullet point is something that we're seeing as a real need and something that needs to be addressed and that we're seeing a lot of a need to focus on, and I'll be talking about that further. So the work I'm talking about today is based on some pilot work funded by the Emory Center for AIDS Research through a mechanism called a CFAR-03, which is very similar to an NIH R03. I'd like to acknowledge the Veterans Aging Cohort Study and the PI of that study, Amy Justice, and several of her key investigators for their support, and also the Atlanta VA Medical Center where that study was conducted. And the title is The Social Determinants of Health of Veterans Aging with HIV in Georgia. It's a fairly ambitious study for a pilot study. I'm actually using multiple methods. We're using survey data from the Atlanta side of the Veterans Aging Cohort Study, in addition to selecting a subset of participants for qualitative interviews. We're conducting spatial mapping and doing multi-level modeling and also doing some grounded theory analysis. So a lot of work from the pilot study. And here are some of my co-investigators and co-authors that I'd like to acknowledge. It's not advancing again. Okay. And based on the qualitative component of the study, we were recently funded for additional research that'll extend this work to 2 additional non-veteran clinic populations. So for those of you familiar with qualitative work, we're going to have a very large qualitative sample, close to 90 participants across 3 clinic populations, including the Atlanta VA Medical Center. We're collecting data at the Grady Health System Ponce de Leon IDP Clinic, which is our safety net hospital clinic, and Emory Midtown Infectious Disease Clinic. These are all very different clinics. The IDP clinic serves some of the sickest and most vulnerable patients in the Atlanta metro area, whereas the Emory Midtown Infectious Disease Clinic reflects the diversity of Atlanta, has a wider range of socioeconomic status. And so this will provide a very rich data set. Very briefly, the qualitative methods, we're using maximum variation sampling to select initial participants, and we're selecting for variation on things like various socioeconomic characteristics, sociodemographic characteristics. We're looking at differences in how long they've been living with HIV. We're looking at functional status. We're looking at sexual orientation, and also selecting based on HIV severity, and I'll show in a minute how we're measuring that. We're conducting face-to-face, in-depth, semi-structured interviews, which are digitally recorded and transcribed verbatim, and we're using a social network mapping tool, which I'll also show. So this is our measure of HIV disease severity. We're using the VACS index, which is a weighted index that uses age and clinical variables, including CD4 cell count and viral load. And a higher VACS index indicates a higher level of disease severity. And we're characterizing our sample pool by this and also selecting our qualitative participants based on this to look at a range of experience qualitatively based on these clinical variables. This is the social network mapping tool. We present this to the participants and we ask them to think of the middle circle as with them in the middle, and we ask them to select people to put in that circle that they cannot imagine life without, that are so close they cannot imagine life without. In the next circle, we ask them to place people who are not so close that they'd put them in the inner circle, but who are also close. And in that third circle, we ask them to place people who still do not fit in those other 2 circles, but they still feel are important enough to put in their personal network. And then we ask a series of questions. We collect some measurable data on structure and function of the networks. We, the relationship how long they've known these people, but then we start to also ask a series of questions related to living with HIV about, do these people know about their HIV diagnosis? We also ask about activities they engage in with their network members to probe for perhaps risky behaviors as well as health-promoting behaviors. And then we also ask them to tell us why they would put the people in the different circles. Why is this person in this circle as opposed to that? And we're getting very rich data based on this, and I'll present some of it. This work is framed by a social determinants of health perspective, and very briefly, it attunes us to the socioeconomic, cultural, and environmental conditions, including social and community networks that influence people's ability to stay healthy. This is the conceptual model that guides this multi-method study. As you can see, we're linking community-level variables, which we're using census data. We're linking it with survey data. And then we're also, like I said, using the grounded theory methods with a subset of these data to get at some more qualitative issues. Okay. Consistent with a social determinants of health perspective, there's a huge emphasis on place. How does place and the people and the places we live influence our ability to stay healthy? Just to provide some context, Georgia is among one of 9 southern states disproportionately affected by HIV disease. We also have a large aging HIV population. Across our 3 clinics, 45 to 65% are 50 or older. The South is also characterized by a large number of HIV/AIDS-related disparities, as well as other health-related disparities. Stroke, heart disease are also higher in this region than other regions of the United States. So just to provide context for where this research is being conducted. Okay, and here I'm presenting some select characteristics of the first 25 CFAR-03 participants that I'll be basing the work that I'm presenting today on. As you can see, ages range from 50 to 72 with an average age of 59, consistent with the VA population. Most are male, but in all the clinics we're oversampling females. 60% are African American among this clinic population. All of them have at least a high school education. In the other clinics, we're finding much lower levels of education. This particular sample has been living with HIV a long time, with an average time since diagnosis of 19 years. 72% have had a prior AIDS diagnosis, and the VACS index score ranges from 0 to 86 with a median of 28. Consistent with a social determinants of health perspective, we're collecting information on their living arrangements and community characteristics. As you can see here, close to half live alone. Their social networks are relatively small, and the number of their close ties are relatively small. Interestingly, although more than a third have been homeless, you can see that this group has a relatively stable living arrangement now. And across the other clinics, we're not seeing this. We're seeing a lot of unstable living situations. So back to the topics that I'll focus on again. And hopefully I'll add some new insights to what is already in the literature. One thing that we're seeing a lot of is this idea of being both a caregiver and a care receiver. We're seeing very frail older people with a lot of health impairments who are receiving care from members of their network, also providing care. And I'll show an example a little bit later about that. One partnered participant is a caregiver to a neighbor and multiple family members, including his elderly partner, his partner's elderly mother, and his own unemployed son. And we see a lot of this, caring for grandchildren, great-grandchildren. And this is something that has not been addressed a lot in the literature, especially not in the HIV and aging literature, this idea of being both caregiver and care receiver. We're seeing, based on the social network mapping, we're seeing that many participants do not disclose to, to either a portion or to their entire social network their HIV status. And this is contributing to their smaller networks. Several, and this is very common in the socially conservative Bible Belt of the South, where churches shun people with HIV. We've had many people talk about how important religion is to them and how important their church family is to them, but many report losing this support. I talked to a couple of patients that said their healthcare providers had even advised them not to disclose to their church members. I talked to one patient who said that he was in the waiting room of the HIV clinic and somebody else from his congregation came in, and even though this other person was also there waiting to see an HIV care provider, he felt like if he returned to church he would be outed, and so he chose not to go back. With these shrinking networks, one thing that we're finding is this phenomenon of weak ties or peripheral relationships. We're finding that these are very important. Here we have a 62-year-old African-American male with nobody in his inner circle. He doesn't think anybody's close, but he talks about this maintenance man. This maintenance man provides a lot of instrumental support. He's in and out of his apartment. He takes him to doctor's appointments and provides a lot of emotional support. And here's another situation. This is a very sad situation. A 67-year-old African-American male with a total of 3 people in his network who refers to his friend up the street who he uses his motorized wheelchair to get up and see for lunch every day. It's a cafeteria worker. This particular participant is living in an abusive situation in a home with his sister who is taking his disability check, and he's confined to one single room. He doesn't have any bathroom or kitchen privileges. He has one sink in his room and a portable commode. And the one person he has contact with is this cafeteria worker. And it's something that he looks forward to and keeps him going. Unfortunately, at the time of the interview, his motorized wheelchair was broken, and he wasn't even able to get up and see her. Another thing that we're seeing over and over again as far as these weak or peripheral relationships, we see a lot of online relationships. People talk about, and some of these are long-term, 4 or more years. And this is, people they meet online who they can talk to about HIV anonymously. And so that's another important source of support that we've seen. And another way we might be able to intervene is to promote some of these what we call weak or peripheral relationships. And resilience is a strong theme that we're seeing over and over despite significant challenges. Here, this is a 61-year-old African-American male living in a low-income elderly group home where he has little or no privacy and needs a lot of care. He says, "I thank God that I lived to get this old. I thank God every day that I wake up." And here's another example of this resilience. A 51-year-old African-American female and recovering substance abuse user says, "I can only do better. If I hadn't have gotten HIV, I probably wouldn't be doing the things that I'm doing now." We saw this a lot, where people actually see HIV as something that saved their lives based on the life they were living. This woman felt like she probably wouldn't be alive now if she hadn't gotten HIV. She felt like HIV saved her life. But one thing that we're finding is kind of interesting is sort of a downside of this resilience is this turning a blind eye to the future. Many of these participants have been living with HIV a long time. They don't want to think about end of life. They choose not to. Few have any plans in place should their health decline, and this includes long-term care, thinking about assisted living, putting a living will in place, selecting a medical health care power of attorney. 2 we interviewed who selected family members as their health care power of attorney have not disclosed their HIV status to them. Some people who said they had thought about assisted living said that they were afraid because of stigma that wasn't an option, so they just, that wasn't an option, so they could not think about it. And I'll provide an example, a creative solution to that in a minute. So here we see, based on the data that I presented, 2 cases where you have 2 males who are close in age and have similar health issues, although patient 5 is doing worse. He's the one I profiled earlier who rents a room from his abusive sister. Compared to him, we have this patient 4 who's been living with his partner for 34 years. His partner is incontinent and spends most of his time in bed. He provides a lot of hands-on ADL care for this partner, but he is essentially blind and can't drive, so the partner is able to drive him to his medical appointments. So that's another example of this caregiver, care receiver. But they've established this enclave of gay men that all help care for each other, and that's their solution for aging in place. They have purposely built this community where all of them have various health issues, but they help each other. Somebody does the yard, somebody cooks. People who aren't able to drive are able to get assistance from other people in the community. So that is their solution to this issue of, what are we going to do when our health declines? So here's the outlook of the 2 different cases. Patient 4, even though he's in a lot of pain and has a lot of his own health issues, he says, with all the pain and everything, life is good. I'm fighting and I know how to fight. Whereas the other patient says, I have had thoughts of ending my life. So this focus on social determinants of health has important implications for best practice in geriatric care, including an increasing push to incorporate social factors into the electronic medical record and triangulate these with clinical variables to provide a more comprehensive care plan. Examples of this in our clinics, some of the providers have known these patients for a long time and are very familiar with their social situations. On the day of the interview with the guy who was being abused by his sister, his care provider was actively working to get him another motorized scooter and also actively working to get him out of his current living situation. And then this ongoing work that we're doing, we hope will provide additional insights in this area. Thank you.